This is FX Medicine. I'm Andrew Whitfield Cook. We're at the 2019 UIC Medical Cannabis Symposium, Tweed Heads. We're speaking with Dr. John Teh. John, welcome.
Thank you.
John, you practice in Brisbane.
Yes.
So tell us a little bit about when you first started using or prescribing medical cannabis. What was your initial thoughts? Why did you use it? And how's that changed over the years that you've been using it?
So initially...
I say using, forgive me, prescribing.
Prescribing, yeah. Had a lot of patients coming to me with polypharmacy, very common.
Yeah.
A lot of pain patients and a lot of side effects from these medications. And been researching cannabis before that from the overseas perspective. And then when it became medically legalised in Australia, I thought this is an excellent medicine, very safe profile. So why not introduce that into my patients' prescriptions?
So you've had an interest in medical cannabis for early days of being a doctor, or before that?
It's a natural progression. At university, we didn't get taught or learn anything about medicinal cannabis, and it became evident in overseas jurisdictions, really. And I just started following that process and got interested in that fashion, and it became kind of a passion for me. So I just delved right into it.
So you're a searcher.
I'm a searcher, yeah.
Tell me about your initial experiences with accessing medicinal cannabis for your patients, and how's that changed?
So 2 years ago, the access is essentially the same as it is now, but it was based on paper. We had the two jurisdictions, so there was a paper form for the TGA and then a paper form for Queensland Health. It would take me over 2 hours to get an application through. They'd have to be posted in an envelope.
You're kidding.
Yeah, so it was old school. Last year, we had the introduction of the TGA portal and the streamlining of the state and the federal systems. So that has really made access a lot quicker, a lot more efficient, and getting a lot more prescriptions through in a shorter time now.
So this is one of the frustrations. I just want to comment on one of the frustrations that's commonly experienced by patients. There are actual movements, positive steps ahead, though, that we've made.
Yes.
It is hastening the access.
Yes.
For patients. There's still that issue of supply and cost. How do you find the supply issues?
Supply issues, at the moment we're still limited to a handful of suppliers in Australia. That limits strain availability, which is a clinical issue. And also a lot of the products are still being imported while our other companies come online to produce in Australia. So I often get a letter from a supplier or an email from a supplier saying, please slow down on prescriptions of this particular medication.
We can't supply.
We've only got enough to supply our current patient profiles. So,
right, which is really unheard of in the plant-based industry.
Yeah, that's like we should have more than enough there. And I think that is just a supply and demand thing, so hopefully that fixes itself.
So you mentioned the clinical issue of which product. How have you learnt? What would be your call out to other general practitioners who might be, hesitant because they don't know enough?
Come to some conferences. I've got videos online giving basic education, and it's a great way to just get your head around the concept.
Yeah.
It's a very complicated medicine when you look into the minutiae, but in reality, as a clinician, it's a very simple medicine. And at the moment, we really just look at the CBD and the THC contents. So they're the only two main things as a clinician you need to know at the moment, and know that it's a very safe medicine, so it can be easily integrated into your patient's prescription regime safely.
One of the hesitancies of some GPs is because of its scheduling as it's still an illicit drug. You're allowed to access it because of special access. But do you think there's still that lingering fear of being judged by their peers, or maybe a fear of what we don't know about the drug?
Most definitely. Both those components are involved. So there's the social perception that has been bred over the last 60 years that it's a very dangerous and bad substance, which is incorrect. And then there's the lack of knowledge base of the majority of doctors who have never used cannabis or been experienced about its use as a medicine and prescribing it. So understandably, as a practitioner, you don't want to prescribe something you don't understand the side effects of. And it's more of a conservative safety factor, which is slowing down, I think, a lot of mainstream use from GPs
Okay, so education's obviously key.
Yes.
You've got some videos and some things I didn't know about this. So
Yes,
tell us a little bit more about this.
Got our website plantmed.net.au, and on there we're posting videos, just short ones explaining different components of the medicine. So THC, CBD ratios, explaining strain, explaining different methods of consumption and administration. So just little short packages of information to fill out people's knowledge.
It's interesting that when you mention the word strain, for a GP, probably the most common way or instance that they'd come across that word would be when they're dealing with a bacterial pathogen. Yeah. And now they're dealing with a medicine.
Well, actually, that's not 100% correct terminology, me saying strain. The correct terminology would be chemovar.
Yeah,
so,
this is an interesting change.
But it's just, that's colloquial language. Strain is what's used in the industry.
Okay, so let's just go into that, a chemovar. So we're talking about a chemotype or a phenotype?
Chemovar
a variety.
They're all cannabis plants. So there's hundreds and thousands even varieties of cannabis. So each separate plant, like we have a green tomato, a red tomato, a stripy tomato, they're chemovars of tomato.
Yeah.
So we're looking at chemovars of cannabis, and every plant is essentially an individual medicine on its own, and that's where we get to the finer points of cannabis medicine.
Yes, I think that this is the hurdle, is that the doctor needs to go back to their garden and look at their roses and look at their pink rose with the variety of...
They're all roses, but you've got
roses.
different smells and different looks and different beauties.
But it's a far cry from the very definite jump of using pharmaceutical medicines, which you are well versed in and confident with for medicine. So where was your jump? What was this historical jump? Was it purely out of just this other people are using it?
Patient need.
Right, that was
patient need, patient demand, patient interest. People, very sick patients with multiple drugs in their systems, lots of side effects which are intolerable, not providing relief for their symptoms, basically coming to me and saying, well, what about this medical cannabis? And that spurred me on even more. And I said, well, let's try it. And it's a very safe product, so you start at a very low amount and slowly increase, and getting really good results clinically.
I have to cover a topic which is dear to my heart, and that's at the beginning of 2018, forgive me, February 2018, codeine was moved to the Schedule 4. That is prescription only in Australia. And there are many people out there that have had addiction issues with opioids previously prescribed. So cannabis has now been touted not as an entry drug to heavier drugs, but actually as an exit drug to help people deal with and help them get off opioids. How do you find this? How do you find the employment of cannabis in this arena?
Amazing. It's really successful. In fact, there's an effect known as the opioid sparing effect, meaning when you're taking opioids and then you combine medicinal cannabis with them, the pain relieving effect of the opioids is increased beyond what you would expect for that level of dosing. So that means effectively patients are having less pain and are able to slowly reduce their opiates and sometimes get rid of their opiates. So patients often come to me on 3 or 4 different opiates and still in pain, and then you add tiny amounts of THC or CBD and gradually move up, and that pain tends to reduce, and then we work together to reduce the opiate drugs in their prescription mix.
Okay, so it was previously explained to me that, and this is a very simplistic definition, but the opioid sort of system, if you like, is when it's a severe catastrophic sort of pain, and the endocannabinoid system is where it's a more smouldering type pain. I'm wondering what about the facility of using medicinal cannabis or employing its use as an adjunct in things like complex regional pain syndrome, where there's this loss of resolution of the pain signal?
That's the perfect situation to use medicinal cannabis, in my opinion, for pain relief. So acute pain, sudden trauma, opiates are the way to go. That stops the acute pain. But once that pain is extended beyond the initial injury or the initial cause, that's when cannabis really hits its forte as a pain reliever. And complex regional pain syndromes, where people are getting unexplained pains with unexplained levels of pain to minor stimulus, I'm getting really good results there with use of cannabis medicines, usually in conjunction initially with their other medicines, and then we slowly remove them. So that's the aim of my treatment modes usually.
We've got some very eminent pain clinics in Australia. Have you seen any movement for them employing medicinal cannabis?
From my direct on-the-ground perspective...
What you've seen, what you've heard of maybe. Through the grapevine.
Through the grapevine, no. Pain specialists... I contact I'll get my practice manager to contact a lot of specialists for me of our services. And in fact, the pain specialists have been the hardest to convince or to get to refer patients to us, which is crazy. But they seem to be the hardest to get over to the medicinal cannabis side. Yeah.
Right. So a lot of people would be... Actually, forgive me, I have to ask this in a different way, and that is, do you find that your patients are aware of medical cannabis and say, doctor, can I use? Or do you say, look, this hasn't worked, I really think we've got an issue here, I think this might be appropriate for you? Is it initiated by you or them?
A bit of both. Usually the patients are looking to try medicinal cannabis by the time they get to me, and often they've been directly refused by their pain specialists.
Right.
They often won't even sign a referral letter to come and see someone like myself. That's changed a little bit in the sense that they can now just get a GP referral, which works fine. In that sense, very difficult. Yeah.
Do you have any particular demographic of patients? I was very interested to learn that older people, who I thought would be rather stoic and resistant to medical cannabis, there was a nurse that was employing it or teaching about its use in an elderly population, in a rehab population.
Yeah.
What's your breadth?
I probably have a more skew towards elderly patients. Yeah. Saying that, I do have very young patients with autism and epilepsy and middle-aged patients, but there is definitely a skew to the older population. I think that's because they are generally in more pain. They've had a lot of time to try and resolve that pain. It hasn't been resolved. So they're still looking to resolve that pain, and as you get older, you get arthritis, you age, and pain occurs. So,
and you use, I would imagine, liquids. Is that right?
Mainly, I use oral oil administration.
Yeah.
Sometimes vaporization, depending on the patient needs.
Okay. So, what's their acceptance about the mode of administration of the drug?
I find most patients are very happy with an oral medication. We're used to taking medicines orally.
Yeah.
Some patients that have breakthrough pain or need sudden, quick pain relief, I'll usually start them on oral medication first, and if that's not sufficient, I'll add in a vaporized medication for quicker efficacy, quicker onset of action.
Need to ask you a question about area under the curve. So we're getting some products come to the market and they're touting, quick access, quick absorption. I'm wondering if that's always what's needed. Suddenly, as you said, you need a quick resolution of pain, but very often we're using it for chronic pain.
Yeah.
What's your thoughts on...
It's definitely patient by patient.
Yeah.
Generally use the oral method because you do get that sort of 8 to 12 hour duration of action. So if for a serious chronic ongoing all day pain, I'll prefer to put, say, a 3 times a day dosing orally, because then you're going to get consistent action throughout the day for pain relief.
Yep.
And then sometimes breakthrough pain beyond that needs to be dealt with quickly, and that's when I'd add in a vaporized product.
And might you employ that sort of thing towards night to help them sleep?
Definitely, So there's many layers of finesse which you can use.
Yeah.
So might just use a CBD product during the day, so it's not sedating, no psychoactive effect, and then skew the more THC heavy products towards the evening, especially initially, because the patient can be then asleep, and it does assist their sleep as well. Often pain patients get terrible sleep because they're in pain. So if you can reduce their pain at night, you're reducing the psychoactive effect, and they get a good night's sleep, and they wake up, they've been asleep. They may not have been asleep consistently for years.
Wow.
Yeah.
Okay, so what about the safety issues the next day when you're operating machinery, driving, things like that? Do you find any issues, or do we have to dispel some myths?
The next day, usually people are not impaired, and it does depend on dose, so you have to get the right dose so that you don't have a hangover effect the next morning.
Is this a THC or CBD?
THC. CBD use it however and whenever you like. There's no hangover effect, there's no impairment of motor coordination or reflexes. With THC, you do have to be careful of dose for the next day. And the official standpoint of Queensland Health and the TGA is that when you're on a THC-containing medication, you should not drive at all.
Right. This is such an in-depth area. I mean, seriously, it's a podcast, FX Medicine podcast.
That's it.
I'd love to have you on the podcast.
I'd love to be there.
We can discuss this in more in depth. Thank you so much.
Thank you.
Dr. John Teh. I'm Andrew Whitfield Cook. This is FX Medicine.